Welcome to day 3 of the 2023 Covering Rare Diseases Journalism Fellowship Program. My name is Rachel Jones, and I'm the Director of Journalism Initiatives with the National Press Foundation. For our first session, part of the challenge of expanding equity in the rare disease space involves fully capturing and acknowledging the barriers to access for people who may have few resources and who are often unable to take even the very first step in what's called the diagnostic journey. This makes the work that our first two speakers do on behalf of their organizations even more important because they can potentially give voice to millions of people around the world. First, Linda Goler Blount is the president and chief executive officer of the Black Women's Health Imperative, the first and only national nonprofit solely dedicated to achieving health equity for Black American women. The BWHI was founded in 1983 by Billy Avery as the National Black Women's Health Project on the campus of Spelman College. BWHI has evolved into a nationally recognized organization that leads health policy, education, research, and leadership development, and it's designed to improve healthy outcomes for Black women. Linda is joined by Debbie Drell. Debbie is the Senior Director of Membership Services with the National Organization for Rare Disorders. Debbie oversees NORD's membership programs, which support the collective and individual needs of rare disease patient organizations, patients, and advocates through education, research, advocacy, and mentorship. Debbie brings over 22 years of leadership in nonprofit public health education, awareness, and advocacy to the organization. Prior to joining NORD, she spent 13 years with the Pulmonary Hypertension Association, which is a NORD member organization. Linda and Debbie, thank you both so much for joining us today. I want to start with you, Linda, because of the profound impact that the Black Women's Health Imperative has had on issues like Black maternal mortality and preventive health screenings and infant mortality in the U.S. But BWHI has also been able to make significant contributions in the realm of rare diseases through the establishment of the Rare Disease Diversity Coalition. So can you please tell us first about BWHI and then take us on the journey of how you made the pivot to rare diseases.
Thank you, Rachel. I would love to do that, and I really appreciate this opportunity to talk to people who are writing about health, because this is, as we saw with COVID, but too many times, the general public doesn't understand a lot about health, and there are forces out there that want to continue to confuse us about health. So I'm so appreciative that there are a group of people who are committed to understanding and really telling the truth of the situation of health, not only in this country, but around the globe. I'm going to attempt to share my screen if I can make that happen, and hopefully that will work. And I just have a few slides. So as Rachel, you mentioned a little bit about the history of the Black Women's Health Imperative, and so I won't go into detail, but for 40 years, we've been the only national organization focused on Black women's health, which in some respects is a little scary that there's only ever been one organization with our focus. But here we are, and we focus on chronic disease prevention and risk reduction. We have the CDC's top performing diabetes prevention program. Maternal health, as you mentioned, we just graduated over 30 doulas from HBCUs, historically Black colleges and universities, because we know doulas are proven to reduce maternal morbidity and mortality. We have a leadership program on HBCU campuses called My Sister's Keeper. We're obviously in the HIV prevention space. We were really undergirded in reproductive justice when Billy Avery started this organization. It was very much around the right to have bodily autonomy. And more recently, we've launched Fair Work, and one might ask, well, why is the Black women's health imperative in a workplace business? And that's because Black women, and we suspect all women, one, define stress as their number one health issue. I don't know if anybody on this call has ever been under stress. And number two, the workplace is the single greatest source of stress. And so we understand now there's 30 years of literature that looks at the connection between stress and all manner of disorders, from poor maternal health outcomes to diabetes to heart disease, all of these things that we've seen. So that's why we're in this space. And what I bring as an epidemiologist is a focus on research and science. And so as we talked about this work, I mean, we're obviously in the policy space because that has to undergird all of the systems changes. But as we looked at the experience of people with various diseases, and you mentioned the social determinants of health, and as we've been talking about health disparities, frankly, since in earnest for 40 years, a group that typically went unnoticed, unmentioned, were patients with rare disease. And so we're used to talking about these disparities in a number of sort of chronic diseases, but as it turns out, patients of color with rare disease, on average, have another 5 to 7 years in that diagnostic journey that you mentioned. It takes another 5 to 7 years to get from appearance of symptoms to get to a diagnosis and treatment. And even when there is a diagnosis and treatment, they can't always expect to get the standard of care. And so we had the opportunity to form the Rare Disease Diversity Coalition, which has dozens and dozens of organizations that are in research and development, policy and advocacy, patient support, caregiver support. These organizations have come together to really focus on solving the problem, because we understand, particularly in this country where we spend so much on healthcare, people ought to be able to expect to get the standard of care, whatever that is. And people ought to be able to expect that if a doctor says evidence-based medicine, that they are included in the production of that evidence. They have some reason to believe that evidence will apply to them. And so the RDDC is very much focused on helping people to understand what is actually happening, what needs to happen, and then providing the supports and collaboration and partnerships across the spectrum to make sure that that can happen. So, we are not only focused on racial disparities, but economic and geographic disparities. If you are a low-income person, you can't necessarily expect to get the standard of care. If you live in rural parts of this country, you're not likely near an academic medical center, so you may not have that. I can only imagine a patient, Rachel, if you were told by your doctor, well, it appears that you've got this rare disorder, but let me tell you, you're not going to get the standard of care. You're going to be ignored. Your symptoms are going to be dismissed. People won't pay attention to you. And you're not even going to be offered a clinical trial if there is one. Imagine how you would feel if a doctor just said that to you up front. Well, this is the reality for a lot of people every day. They don't know it. Nobody's saying that to them directly, but they're experiencing it. They're wondering, why is it taking so long to figure out what's going on with my child or with me. Earlier this week, Rachel, you shared with me Victoria Gray's story of living with sickle cell. So many patients show up in the emergency department in pain, in crisis, only to be accused of opioid seeking, having to consider the very real possibility of incarceration because someone thinks they're seeking drugs and doesn't believe they're actually in pain. I have my own personal story, which I'll just mention briefly, but I think it's an interesting study in contrast. My daughter started having symptoms that nobody could really explain. She went through a number of tests, doctors, you all kind of know that diagnostic journey. We couldn't seem to get any real answers. Well, at that point, we picked up the phone, her father, a physician, her mother, an epidemiologist, and called the chair of the board of a leading hospital and research center in New York. We called, leading nephrologists. We called all kinds of specialists to try to find out what was going on. And so, when you can call the chair of the board of a hospital system, you can get some attention. You can get somebody to pay attention to your child, your situation. Well, the vast majority of us can't do that. So many patients are in literally a limbo of confusion and fear because they just don't know what's happening. So the Rare Disease Diversity Coalition, all of these groups, and there's many more than are on the slide, exist to get rid of that fear, exist to bring solutions to patients, exist to bring clarity so that mothers and fathers and caregivers can have a plan, can have some sense of what is going on, have some next steps, know that there are groups like you see on this screen advocating for them, knowing that there are people like the staff of the Rare Disease Diversity Coalition, but also these groups who are in the halls of Congress in Washington, D.C., talking about the kinds of policy solutions and working with researchers to make sure that when we talk about evidence-based medicine, we're actually including everybody. So just a little bit about some of our accomplishments. As I said, we're very much focused on solving the problem. So we're looking at these issues from a provider perspective, the patient perspective, the caregiver perspective, obviously policy and clinical research. So we launched Know Your Family History. One question that is so critical for patients to be able to answer is, what is my family history? If there are symptoms that are inexplicable, we're trying to work through this process, knowing your family history is really critical. So we've launched this pilot so people can know what kinds of questions to ask, what kind of information to get, so that they can have a really productive conversation with their caregivers. Debbie's going to talk about the survey that was launched, which is really historic in nature, and we have thousands of responses to understand the barriers to care that people are experiencing. We produced a comprehensive report on DEI in rare disease. Certainly the journalists who are based in the US have seen this, but maybe even some globally have seen that in the last year and a half or so, there's been a real de-emphasis on diversity, equity, and inclusion. We've seen the whole departments eliminated from corporations, people lost their job. I literally had a funder, who shall go unnamed, tell me, well, you've had your George Floyd moment. So there's this sense that we no longer have to deal with diversity, equity, and inclusion. But absolutely, we have to. And so the Rare Disease Diversity Coalition is looking at what that means for rare disease. We've piloted a highly successful fellows program where we bring fellows in, train them in rare disease, so that these people are able to not only advocate, but offer the best care and be aware of the kinds of barriers that patients and caregivers face. We launched the Rare Health Equity Conference Scholars Program, again, focused on early career professionals. And we were the co-sponsor of the third annual Rare Equity Conference in 2023. So a lot of organizations are looking at equity, but what the Rare Disease Diversity Coalition does is it really puts it in context. It brings the data to action. It helps people understand what is really going on, but more importantly, what can actually be done. We're in the policy space looking at the FDA draft guidance on decentralized clinical trials. Again, this is critical to address diversity issues, because if you don't happen to live near an academic medical center, first of all, your physician may not even be inclined to suggest a clinical trial for you, but it may not be possible depending on where you live. So we've got to figure out a way to bring clinical research to patients rather than force patients to go to clinical research. And we're obviously cultivating relationships at all levels in all geographies with healthcare leaders in Washington, D.C., but also at the state level, so they understand how important these issues are. And just a little bit of our resources. I just want to, point you all to rarediseasediversity.org, where you'll see a number of resources, reports, guidance. Again, you will get access to the Know Your History toolkit so that you all can actually see how that works. You'll look at what we are actually doing, how we're talking about these issues. We're taking approaches in communication that make these issues accessible. So we're trying not to use a lot of jargon and scientific speak, but we're really incorporating the lived experiences of patients with rare disease who have historically been left out of not only research, but frankly, omitted from the standard of care. So we're building on our commitment, reaching out to students and their training so that this next generation of providers that comes along will be aware that there are real barriers. I'll just sort of kind of wind this up with, Rachel, we talk a lot about advocacy and patient advocacy and how important advocacy is, and it is, absolutely. But what we sometimes perhaps inadvertently end up doing is putting an enormous burden on patients to be advocates. Our feeling around within the RDDC is, yes, advocacy is important, but we can't make that solely the responsibility of the patient. The patient shouldn't have to be a medical specialist. The patient shouldn't have to be a social worker or a psychologist. The patient has enough, and his or her caregivers have enough on their plate simply because they're dealing with a rare disease. So while we are building, you'll see with the members of the coalition, the sort of the muscles for advocacy, we know advocacy is a luxury. You've got to have money, you've got to have resources, you've got to have time to be an advocate. And too often, providers look at patients who don't seem to be strong advocates as not being interested. Nothing could be further from the truth. You have a rare disease, you have a child with a rare disease, your life still has to go on. You still have to go to work. And so the Rare Disease Diversity Coalition understands that and takes into consideration the lived experiences of patients and those who are caring for them so that they don't have to be burdened by the expectations of advocacy. So I want to point you all to February 28th next year, where we'll have on the eve of Rare Disease Day, our reception. We had a lovely one last year. If you all are in town, please come participate. You'll hear more about RDDC. We'll be offering the RISE Awards to those stalwarts in the space. And, I'll just end with, this issue is so important, and we tend to sort of compartmentalize rare diseases. But I think you all have heard probably many times by now that rare diseases, frankly, if 10% of the population is living with a rare disease, are not all that rare. And so they are absolutely deserving of our attention, our research, our advocacy, and our policy. Thank you.
Linda, thank you so much for that presentation. I personally have a list of questions that I'd love to ask. Before we pivot to Devi, I did want to ask you if you are comfortable sharing with us a bit more about your daughter's story and what you were able to accomplish.
Yes. So she, as I said, developed symptoms. It turned out that she has a rare kidney disorder, FSGS, I know, focal segmented glomeruloscleritis, just this long name. Idiopathic, no family history. We have no idea how this happened. But her symptoms appeared, and there were all these tests that in the end had nothing to do with what was actually happening with her. And having the parents that she had who were very impatient with the medical system, and again, her father is a physician, we literally ended up calling the people that we knew. Again, we had some thoughts about what could be happening. So we called leading specialists around the country. She was being seen in New York. We called, like I said, the chair of the board, the president of major hospital system to say, look, we don't know what's going on. Here's what's happened. Here's what we think. We need you to do these things. And so we ended up Rachel, getting her tests and getting her seen by a leading nephrologist who probably never would have seen it. Had we not had our connections and had the money and resources we had, this person would never have seen Stephanie. In the end, she got wonderful care. She got some novel therapeutics. There was a point she was literally just married, I mean, months into her marriage, and she was very concerned, obviously about it, about life, but having children, well, she now has a 20-month-old daughter who is beautiful, wonderful. She's happy, she's doing well. And, I just have to say that, it shouldn't have to be because she had the parents that she had. Anybody should have been able to get that standard of care. And so that's why I'm committed to the Rare Disease Diversity Coalition, because it shouldn't be who you know. It should be, I'm a patient, and that's all it takes.
You're setting us up brilliantly for our discussions with Anna Greca of the Broad Institute later, and also for our end of day conversation about social determinants of health. So thank you for that. We're now going to shift to Debbie. I have to confess that I spent a lot of time stalking Debbie on LinkedIn. Her posts about her work and her passion around rare diseases was so compelling to me that as I was planning and organizing this summit or this fellowship, I knew I wanted to maybe try to get her involved. But then I saw her at the NORD Breakthrough Summit in DC and heard a compelling story that she told, and heard her talk about the caregiver barriers survey that she's going to tell us about. So, Debbie, why don't you just introduce the rest of us to you, since I know you so well. But tell us your story and then tell us about your work.
Yeah, thank you. I do have some slides. I love storytelling, and it's a real honor to be here. I'm going to see if I can do this. Okay, so I'm the Senior Director of Membership at NORD, and there we go. I apologize, I had a technology issue, so I have a laptop and I'm using my phone for video. But I'm a second-generation Mexican-American, daughter of undocumented immigrants. My mom got citizenship not too long ago, pre-pandemic, and I started working in, after college, I started working in the women's movement, in grassroots organizing for reproductive health. And then someone I loved got sick with a rare disease, and I started working at the organization dedicated to her disease. And I was there, as you mentioned, the Pulmonary Hypertension Association for 13 years. And now I'm really honored to be, or blessed to be, working at NORD, which is the oldest umbrella organization in the United States. And people ask me, which rare diseases do you work on? And I say all 7,000 of them. And that's what NORD does. We work with all 7,000 rare diseases. Our mission is to improve the health and well-being of people with rare diseases by driving advances in care, in research, and in policy. And so for those people who are going through diagnosis and they're getting misdiagnosed, the quality of care matters. If a disease is a ticking time bomb and it takes you a long time to get diagnosed, the quality of care that you have access to matters. Research, if nobody knows anything medically, the medical research communities do not know anything about your disease, you don't have a chance. There's not going to be any treatments for you. And 95% of rare diseases have no FDA approved treatments. And when it comes to policy, rare diseases are not they were not recognized. They were considered orphan before the 80s. People didn't talk about them. They were taboo. If you had a rare disease, you were alienated. And still today, there's a lot of stigma around rare diseases. And so for policy, there's a lot that needs to change, from how we screen babies through newborn screening to how we implement access to care and insurance, telehealth, and then just there's so much in the policy, and I know that my colleague Karen Holzer had spoken earlier about the Orphan Drug Act. That was the first way that we used policy, and that was the foundation of NORD. Was when the Orphan Drug Act was approved, it was really parents and patients. A woman named Abby Myers had a son who had Tourette's. And all these patients came together. They might have had an organization that was recognized as a 501c3 or not, but they all came together to advocate for the Orphan Drug Act because they were orphans. No one wanted to fund the research for a drug that it takes so much money to develop a drug. And if you don't have a large patient population, you're not going to make any money off of it. So the Orphan Drug Act was the big seminal policy, which one would say, oh, you've got the Orphan Drug Act. Our work is done. And in fact, that was 40 years ago. And that was just the beginning of the work that they were doing. So NORD adheres to a vision that guides our efforts to improve the health and well-being of people with rare diseases. And I know you'll hear from other NORD staff members. I do want to talk a little bit about the rare disease diagnostic odyssey and all of and you may know this already, but when you have a rare disease, you may look very sick. You may have issues with your arms, your fingers, your face, your posture, your walk. You may be physically disabled in a wheelchair. And there is so much isolation and stigma when you're rare. No one knows what it's like. And you may be the only one you know. If you have a rare disease and you don't look sick, then there's issues there in terms of how you're cared for. And there is a new movement among rare disease parents where they're trying to stop false accusations of medical child abuse. So a lot of parents are being accused of child abuse because their kids don't look sick. And so that's an issue that is emerging. And there was a Netflix special about this over the summer. So there's so much, whether you look sick or not. 95% lack treatment. There is not a lot of expertise or information. And I still talk to people. Yesterday, I talked to somebody who their daughter has a rare disease. She has one eye missing. She has bone abnormalities. And the only two other cases that they know of were diagnosed in autopsy. So the babies died. And so they're really isolated. They really have a population of one. And so, and then there's the diagnostic delay that you're getting worse and worse. And for people, for communities of color, for rural populations, for those who are experiencing the social determinants of health, where it's, getting medical care is not the top of your list, even if you're dying, that this is a real problem in the community. And health systems are not set up for rare diseases. And so the presentation that I'm going to give is focusing on a result of a survey that we conducted with the Rare Disease Diversity Coalition. And essentially, we did this because we want to have legislators, we want media, we want the world to know, how do marginalized communities access care and what are their barriers? What is stopping? What is preventing? What is holding back populations that have not been included in the dialogue? What is it that's stopping communities? Why is there a delay? Why is there a higher level of mortality? And so that's what we're looking at, because there hasn't been this attention. So we want to listen to and learn from underrepresented communities. We want to better understand their experiences, and that barriers to care is a huge question. So I'll just tell a story of a young woman named Alex, and she had her third baby living in Texas when she started to slow down. And she is a Latina, 28 years old. And she went to her doctor and said, I'm having a hard time breathing. The doctor gave her asthma medication, a steroidal inhaler. She went back to continue to help take care of her three babies. And she got worse. So she came back and they said, you need to lose weight. So then she started exercising, and then her heart started to feel really heavy in her chest. So she came back and they said, it's stress. So then she took Prozac, and on and on. She saw 12 different doctors in this small town in rural Texas that has a population of 8,000. I think I have more Twitter followers. And was it that she was living in a rural town? Was it that she was a Latina? Was it that she was a young person? Was it that she was a woman? Or was it that she had small babies? What was it that delayed this diagnosis? Or was it that rare diseases are hard to catch? Could it be all of these things? And we know that rare diseases in of itself, if public health is about populations, and if a population within public health has all these intersectionalities, a young woman of color, this is hard to understand exactly where the breakdown happened. And so the doctors told her, you're not going to live to see these babies of yours go to elementary school. You're not going to see them go to high school. You're not going to see them have a quinceañera. You're not going to see them go to prom. And she had to take care of these three babies. And her husband, unfortunately, this is part of her story, her husband signed up to go to the Iraq War because he couldn't handle three babies and a wife that was dying. She couldn't get out of bed. And so these are the babies. So these are the babies. And they said, they told her in her diagnosis, when she finally got diagnosed, she was so far advanced. They said, you have 6 months to live. You're 28 years old. I'm so sorry. You're not going to live to see your 30th birthday. And these are her babies that she had to think about what could she do now? And all through this, she didn't think, oh, well, I didn't get the right diagnosis. When I first started presenting symptoms, you should have done, like, the first thing on her mind was, who's going to take care of these babies? And the time that she was diagnosed in 1998, a drug was approved by the FDA. And the doctor who told her she wasn't going to live to see her 30th birthday also said, I've never seen this before. It's this disease called pulmonary hypertension. The medical literature in 1998 was not accessible online. So he looked at the textbook and there was 2 lines, life-threatening mortality rate, 50% within a year. And the way that it had advanced, the size of her heart, they said, you're going to die. But the doctor said there's a specialist I know of that treats some patients with this disease. And so he sent her to the specialist. The specialist immediately put her on the medication that was approved. And that specialist said, we don't know how long you have, but we need the treatment. I apologize. Okay. And they put her on the treatment, and that drug was approved because an organization existed at the time. And the organization, 10 years before her diagnosis, that organization was fueling research. That organization exists because the patients in 1990 wrote letters to NORD, the National Organization for Rare Disorders. They wrote letters to NORD to try to find each other. NORD helped the first patients come together. Those patients started a nonprofit. When those patients who started the nonprofit held a medical conference with patients, they went to NORD and said, should we bring in scientists? They want to research and draw blood on our patients, and we don't know if that's appropriate. NORD said, that is incredible. Yes, you should do that. And the doctor said they drew more blood during that conference than they would in the entire year, because the patient organization brought all the patients together. And as a result of this organization, a drug was developed and approved the year that this person was diagnosed, that this young woman was diagnosed. They put her on treatment, and she lived to see her babies. She lived to see her babies have babies of their own. And these are her granddaughters. And it's a miracle. It's a miracle that she got diagnosed, that she didn't die in autopsy and get diagnosed then. That person is my sister. My sister was diagnosed with pulmonary hypertension. And actually I'm getting emotional because she just got another diagnosis of right ventricular heart failure. And the odds on that are not good. And she needs to change her lifestyle plus treatment. But she's been living with this disease for 25 years. And I believe that it's because of NORD helping patients find each other. It's because of those patients who had the ability and the privilege, honestly, they had the time and the ability to start a nonprofit, and that those patients worked with the medical community. That is why this organization existed. And I worked at Pulmonary Hypertension Association in her honor. I was so grateful they saved her life. And then I went to NORD and was very grateful to keep serving all 30 million Americans. Alex does, as her advocacy, she doesn't have time or energy, but what she likes to do and contribute is she likes to make graphic arts. And she does it for Awareness Month, and November is Pulmonary Hypertension Awareness Month. So I wanted to share that. So it's, I don't get that emotional when I talk about my sister's story, but it is a roller coaster. And even if there's a treatment, and with pulmonary hypertension, there's actually a dozen treatments. And so one can say we're very lucky because 95% of rare diseases do not have treatments, and death is an unfortunate story. Your stories are so important for diagnosis. Your stories are so important to empower people. And Alex actually, in her small town in Cuero, Texas, wrote a letter to the editor about her disease and found another patient. So just telling the story of rare diseases empowers patients to find each other, to know that there's hope and that there's clinical trials and research that they might participate in. What we're doing with the Rare Disease Diversity Coalition is unbelievable. We've never surveyed across all 7,000 rare diseases, asking them about barriers to care in this way. And so we used SurveyMonkey. We surveyed them we started the survey this year on Valentine's Day, and we continued for 4 months. The survey was available in English and Spanish. All the data was collected anonymously because we wanted to have safe participation. People said, why didn't you collect the names? And be able to follow up. And we know that some people don't want to leave their name when they're filling out a survey. Don't want to put that, if they're putting all this information about their insurance and how they access care, there's a level of trust and wariness around data collection online. So we didn't do that. Our inclusion criteria were if you were diagnosed with a rare disease, if you were suspected of having a rare disease, if you're a loved one and you care for someone. So I could have taken the survey. I did as a beta tester. And if you're a caregiver who your loved one has passed. And so those were the criteria. So undiagnosed, diagnosed, and caregivers. And we wanted to know specifically what the barriers to care. We asked we had six, it was a very extensive survey. It took 20 minutes to complete. And there were questions about your rare disease, when were you diagnosed, how were you diagnosed? There were questions about health insurance, if you're covered, the type of insurance, secondary insurance that you may have, costs that you estimate per month just for the insurance, what kind of care do you have from your insurance, and questions about how they use healthcare. We asked about the transportation to their rare disease doctor, how long it took to get to their rare disease doctor, the number of hospitalizations, ER visits. And then the section that was, to me, the most critical was their experiences with healthcare. What are their barriers? And so the results of the survey are not out. That they will go out in February. I'm going to actually reveal to you what has not been shared widely, which is the response to the questions about barriers. But I also want to share just a little bit about methodology. You helped us, and we can't thank you enough as members of the media, helping us distribute the survey. We did grassroots. We promoted it all around the country. We used little postcards. We worked with ethnic-based advocacy groups, LGBTQ groups. We worked with our NORD advocates, our social media, but you amplified the message by putting it in. And we actually paid through Google. We paid for sponsored ads and video promotion, but we needed every way, shape, and form that we could to promote this survey. And we even put it, I apologize. I'm advancing the screen in one way, but it's not doing it here. Okay, so we went across the country, and as you can see, the postcard here in Spanish, but we needed every aspect of promotion. Some people are more easily reached through media. And we had, let's see if this works. Yeah, I think that's working. Yep, so thanks to the Black Women's Health Imperative, with a spot on a billboard in Times Square, we literally had this, for about a week, showcasing to just try to get as much as we could. So, we tried every way that we could to get the word out about the survey. The results of the survey, we had a poster session at NORD's Rare Disease and Orphan Products Breakthrough Summit. I'm sure that this is impossible to read. But I'm going to reveal the survey results to you of what we are able to share of the barriers. Our goal was 2,000, and we got 2,848. So we went above and beyond 150% almost of what our target goal was. And what was shocking was that the number of patients, not caregivers, who filled it out, because 50% of all rare diseases are pediatric. So you would imagine it would be a 50-50 split, but patients were incredibly motivated. Communities of color and other populations that we targeted were themselves living with the disease, took the survey. And then in terms of the breakdown, we identified underrepresented as Black, Indigenous, people of color, those with Hispanic ethnicity. We had a zip code analytics analyze. So we didn't tell people, where they live, city, state. We just got the zip code and did the algorithm. And then we have a household income poverty limit, a federal poverty limit for household income. And that's how we were able to aggregate and define underrepresented. And 42% were underrepresented, which our goal was 60, but 42% was still pretty good. And but when you have data, when you have almost 3,000 pieces of data, the percentages here, it's really good for our significance testing. So I already mentioned the survey questions, but when it comes to the barriers, we asked about their interactions with their providers, their attitudes towards genetic testing and genetic counseling, the travel time, which is an actual barrier, and then their perceptions of barrier. We asked about visual hearing ability and any citizenship, language, and emotional, psychosocial barriers. And we have a qualitative open-ended question, which will take a little bit of time to code and analyze. But this is it. This was the question that, and there's a next slide that will show, but that really focuses in. But we had so many different markers. Which of these markers did you experience that caused you to either delay or just not get care? And if you delay your care, your symptoms can be exacerbated, your disease can progress, you may die. Like my sister, unfortunately, her heart was in a terrible condition. Her odds may have been better if she were diagnosed earlier. So what are the following reasons that in the last 12 months, and the number one, this is across all 2,800. This isn't for just communities of color. This is for everybody. So this is painting a picture of rare diseases. You are overwhelmed from managing your life and from caregiving responsibilities. That's number one. Half of them had that. And so our population, 42% of the survey's respondents were these marginalized communities and subpopulations. So you would say that if it's 50%, that it's going to be, mostly 50% across race, ethnicity, socioeconomic status. The thing here that was shocking, and I'm sorry about the way this slide turned out, that number, the 9% one is covered. But the thing that's most shocking here is that 17%, almost the second to the last, you experienced housing instability, food insecurity, or you were worried about your basic needs. And so this factors into the social determinants of health. This factors into these subpopulations in these communities, these disparate communities, that almost 1 in 5 experience housing instability or food insecurity, these basic needs. That is a staggering statistic. And if we're thinking about 30 million American and 1 in 5, we've got 6 million. It's really tragic. And the rare disease community has not talked about this. It's not a focus. The focus for rare disease communities, let's get research, let's get clinical trials, let's develop drugs, let's get funding for research, let's get diagnosis. But we need to collectively think about this, talk about this, do something about this. And the other elements for this barriers question, feeling stressed, anxious, drained, or hopeless also needs to be addressed. And it is part of the dialogue in our community. You couldn't afford the cost of the visit is 1 in 3. So that's 10 million Americans. If we look at this, of the 30 million Americans, 10 million Americans can't afford to go to their doctor, and they're not going. And that's a policy issue. Access to care, that is community health possibilities. Almost 1 in 3, your doctor didn't take the time to listen to you. Now, the analytics that our epidemiologist on staff, our director of research, what she's doing is she's going to cross-tabulate the data to understand, of those who could not afford the visit, how many of them were communities of color. What is the difference between marginalized communities and not marginalized communities, communities of privilege? What is the difference with these barriers? Is it disproportionately these marginalized communities? Are any one population more affected than others? And the last that is covered up by text, and I apologize for that, the last barrier here is you were worried about being able to fill out the forms, and you were worried about understanding what you're supposed to do. And that's 9%. Now, in my mind, as a Latina woman, immigrant, and a daughter of immigrants, and knowing the Latino community, that they're the fastest growing population in the United States, and that their barriers to care are severe. Knowing that, I imagine that this is a language barrier and a health literacy barrier, that 10% of those surveyed didn't go to the doctor because they were scared of filling out forms. They were worried about filling out forms. That is a big problem. Worried about putting their information in, worried about misunderstanding, and so they just chose not to go. These are the problems that we are experiencing, and that's just the one sort of major question of the survey, and we will have more findings on actual barriers, perceptions of barriers, and it was a multi-stakeholder project. We worked across dozens of rare disease organizations, of ethnic and other health organizations, because the Rare Disease Diversity Coalition is also an umbrella, an incredible organization. So we just collectively did this survey. We got unbelievable response rate, and we now have the best data to look, to learn. And now we have to investigate and look more in a more refined way what we're going to do. And we only have 10 minutes. I had other stories to tell about how NORD worked with the Amish community, who do not use technology, to get them to participate in a meeting 300 miles from their home. NORD also conducted listening sessions with Latinos in 4 cities. And we did 4 of them. We did one with Montefiore and the Bronx, and what we learned. And we also did a DEI series for rare disease nonprofits. How do we change nonprofit organizations when 80% of their boards are white? How do we change that? What does that mean for rare diseases? So there's so much there, and I apologize for talking too much about the storytelling of my sister's story, but I'm so happy to be able to share this and with all of you. You have such an incredible role and are making a difference for our community. So thank you for your work, and thank you for having me, Rachel.
Excuse me, you have both done such a tremendous job of breathing life into this topic of how do you quantify barriers? How do you communicate to people the impact that these barriers have on quality of life? So while I wait to see if there are any Zoom hands, I want to quickly ask both of you to expand just a little bit more on this issue of the post-George Floyd moment. Linda, that really hit me like a sledgehammer when you said that, because for the work that you do specifically, are you seeing pushback? Are you seeing people finally saying, enough already, we're tired of hearing about it?
Absolutely. There's a phenomenon in philanthropy, which is this donor fatigue around DEI, anti-racism, health equity kinds of issues. And there's this, among some, this sense that enough's enough. And so if you look at organizations like mine, in certain sectors, they will tell you fundraising's down from certain groups, where it's like, okay, we're good, we're done. But what's sort of at the heart of this is this feeling that you all should have been able to deal with this. But obviously, Rachel, these are systemic issues. These are not issues for any one nonprofit group to deal with. This is a system, and we've got to change our behavior as a system to decide that people are valuable. And if they're valuable, then they are worth getting good care. They are worth participating in clinic, including in clinical research. They are worth, being paid a fair wage for their employment. Many issues. And so this is not uncommon. We have seen this sort of cyclical, almost backlash many times throughout history. And I'll just, give you sort of a quick data point. A Harvard Business Review studies show that 5 years after companies go through DEI training, they're less diverse than when they start because of this backlash, this response to this. So we've got to figure out another way, I think, to talk about this issue, to frame it, to offer solutions, to try to not elicit that kind of response, but to kind of move forward and get the progress that we're really trying to achieve. Because it's clear, if magically we could get rid of all the isms, racism, gender discrimination, income inequality, all of those isms, everybody does better. I mean, it is not just low income people or people of color. Everybody would do better. That the data are clear on that. We've got to figure out how to make people really understand it and then act on it.
I hope the both of you could stay at least 5 extra minutes for us today, because we are seeing some Zoom hands go up. I want to start with Nadima Umar Uthman from Ghana.
Thank you. Hi everyone. Thank you, Debbie and Linda, for those presentations. I just want to find out, and I love the fact that Debbie emphasized the importance of data collection when it comes to rare diseases. I'd like to find out what the state of screening babies for rare disease is in the United States, because before I joined the fellowship, I met a young woman who she sells bottled water in the market. She barely earns $1. And then she found out that her first child, after so many years, was diagnosed with mucus polysaccharidosis. I hope I got the name right, type 4, I think. And so already she is not educated, she's not literate, so she does not even understand what is happening to her first child. Then she has 2 more kids, and then she realizes that all 3 are showing the same symptoms. Now, this is a woman who can barely feed her family. And then it's also impacted her relationship with her husband, because unfortunately in Africa, we're also dealing with issues of superstition. When you present, or a child comes with a condition that a lot of people don't know much about or don't know that it exists in the first place, then people start asking questions like, how come the child is suffering from this condition? And so eventually the husband actually abandoned the children. So she's now stuck with 3 kids. She does not know what's happening in a country where health issues, access to quality medical care is largely missing. And then she comes to you, the journalist. So when I told her story, she wanted me to help her with funding so that she can get help for these kids. But unfortunately, the funds has not come. I am looking at, and I am Debbie, I think Linda in her presentation mentioned that healthcare should not be about who you know. It should not be about who your parents are. And then this person, she doesn't know anybody. And so I'm wondering how screening for babies, if it had been done for her, could have prevented her subsequently from maybe the rest of the children going through this, or she would have at least known what to do. Thank you.
Yeah. Thank you for sharing that story. And that is unfortunate. And that is sort of the global environment that we live in. In the United States, all babies in the United States get newborn screening. 4 million babies are screened every year. And most states report like 99.9% of people who are doing newborn screening, they're participating in newborn screening. The latest CDC data show that 12,500 newborns are diagnosed every year through specific conditions. Newborn screening doesn't cover everything, but it does cover a lot of rare diseases. 1 out of every 300 newborns are eventually diagnosed. So we're really, newborn screening is incredible, and it is something that we continue to advocate for expanding the panel of the types of diseases that are diagnosed. 80% of rare diseases are genetic, and so newborn screening has the hope for capturing
those patients, those babies. And when they are diagnosed and there are treatments, it can save their life. It can change their whole outcome and their trajectory.
Before we go to Manuela Calari, I wanted to ask Jasmine Bazan to jump in because she mentions that gender equality is one of the big challenges in Argentina. Jasmine, do you want to talk about that?
Yes. When she immediately when she said the whole George Floyd moment being over, which is so cynical and so I don't know, so terrible. The same thing is happening in Argentina with gender equality and gender issues, not only in rare diseases, but in founding in general. We had a Ministry of Women created a couple of years ago, and now they are talking about closing it. They are saying that we went too far with human rights policies in general. Well, this is what is being discussed in the upcoming elections, so it's terrible. That's what I wanted to add. And the work that you're doing is so amazing and so necessary, and I hope I can only hope that the same work can be done here in Argentina.
That is such an important point. I'm so glad you brought that up. Thank you. Let's go to Manuela from Italy, Cosmos Magazine.
Yep. Thanks, Rachel. My question is for Debbie. I'm not sure if I missed this during the presentation, but can you confirm that the results you showed us are from across the people who participated to the survey, and also whether you did analyze the same values for each of the two groups that you presented at the beginning, the underrepresented and the represented population?
Yeah, we're doing the analysis to compare between marginalized and not. But what I showed in the PowerPoint, and I'm happy to share the PowerPoint, is across all 2,800, so the total sample size.
Okay, thank you.
I think I'll give the last comment to Julia Matreau. Can you speak, Julia? I know you have to worry about your roommates.
Yeah, I can speak quietly if you hear me like this. My mother is an Ashkenazi Jew. My dad would not have been a carrier anyway, but I was an IVF baby born in 1997, and before they did IVF, they screened for Tay-Sachs. And I know there's an interesting thing in some Orthodox Jewish communities where they do matchmaking. If they do matchmaking, they literally test people for Tay-Sachs before the matchmaking process starts. I can say, as someone who lives with a rare disease and other disabilities, Tay-Sachs, as with a lot of research now, living into adulthood or living past 5 is very rare, versus some other conditions where you just need more support and more treatment, etc.
Once again, I feel as though I wish we had an extra hour to keep talking about this because this is so important. But I'm going to ask both of you to end or send us off with some advice. You've shared with us the difficulties of doing this work in a space where, as Debbie mentioned, 80% of many nonprofit organizations are white, and trying to impress or impart the importance of inclusion is a challenge. Would each of you advise the journalists on going back into their newsrooms, for some of us, particularly in the West, in the US and UK, going back into our newsrooms and trying to communicate to our editors the importance of doing these stories? What advice would you give journalists?
Well, I would say start with the patient, end with the patient. But the thing that I think is really important for editors to know as these stories are being written is these are systemic issues. these issues, patients are not having these experiences because they don't care, or are doing something or not doing something. People who live with rare disease, as Debbie pointed out, you're looking at half said managing my life, that they're trying to fit this rare disease into their lives and manage it. They can't stop their life to deal with the rare disease. And so what ends up happening is people get this impression that among certain groups, people of color and low-income people in particular, that they just don't care, they're not that interested. And as I said, nothing could be further from the truth. So, as these stories emerge, make sure that you're talking about the systemic issues that create real barriers, as well as care delivery barriers, because not everybody has access. Even if you have health insurance, does not mean that you have access to the standard of care. So that full story needs to be told about the true lived experience of the patient.
Debbie, what are your parting words for us?
Yeah, I think Linda said it best. But on top of that, I guess an extra layer would be that the patient voice is so important, and people like the Rare Disease Diversity Coalition, Black Women's Health Imperative, and NORD are here to help you find the voice of those who are not often given the voice. So come to us, talk to us. We are here for you. We can help you find those voices of patients whose stories have not yet been told, but who represent 300 million people around the world who are experiencing unbelievable courage and also great pain and suffering and struggle to get diagnosed and to get treatment and care. And we've already heard 2 stories just in the chat. And in this group of people experiencing, it's 1 in 10 in the United States if we're looking at 30 million. And there are so many who have not yet to be diagnosed. So your stories are going to save lives, and you have to keep telling them. And we're here to support you. And whenever I get a journalist saying I'm doing a story, I drop everything to get the community that you're looking for and to find the best story to share, because we know how important it is. You amplify a message of those who don't often have a voice. So thank you.
Well, thank you, Debbie Drell of NORD and Linda Goler Blount of the Black Women's Health Imperative, for fueling a powerful and important discussion about equity and access in the rare disease space. Thank you both for joining us today.
Thank you, Rachel.
Thank you.